Please.
Chandrakant sir is there.
Yeah. Good evening. Good evening. Good evening, Sanjay sir.
Hi, Chandrakant. Chandrakant, so you will conduct the proceedings today. You seem to have done a lot of homework, so I will just watch and then.
No, sir. No, sir. You will drive the show, sir. You will drive
Serious
it.
about it, Chandrakant. So I'm there. I'm there. So wherever I
Sir,
think
sir,
I
no,
can
no, no,
add
sir.
value, I
No,
will.
no, sir. Sir, I request you to drive the show. I'm there to learn also, sir.
Very good. All of us are. Anyway, so Nihanti, we can start.
Okay, sir. Okay, good evening, everyone. This series is going to be the first session of the ISMPO Journal Club. So, prior to the start of the session, I would like to thank Dr. Padmat sir and the entire team of ISMPO for organizing this session for the students. I request all the students to actively take part, and whatever doubts you guys have, we have eminent faculty today. We have Sendil sir with us, Chandrakant sir, and Akkal sir. I request everyone to actively take part and please post your questions. And we are going to divide the session. The two moderators would be Dr. Chandrakant and Dr. Akil Kapoor. Both are experts in the field of conducting a clinical trial and dissecting a trial. And the final take and the expert talk would be by Sendil Rajappa sir. We have three students, and I thank all the three volunteers. Dr. Syed, who is a first year student of MNJ from Hyderabad, Dr. Rupam, who is a final year student of NH Howrah, Kolkata, and Dr. Shubhra, she's a final year student of TMH Mumbai. Without wasting much time, Chandrakant sir will be taking the further dice. Sir, sir, you're muted, sir.
So thank you, Dr. Nihanti. And it is my privilege and an opportunity to be initiating an ISMPO initiated a unique journal club monthly. And we are not just focusing on the new trials, we are focusing on practice changing trials and each month addressing one DMG with the expert. So this is a unique initiative. I think Dr. Padmaj brainchild and Dr. Smriti ma'am's brainchild and Dr. Vinayak has been very instrumental in supporting us for this. So, well, the whole purpose of here is not just to discuss the data of a particular trial, but it is to understand how to read a clinical paper and how to interpret and how we can take it to practice. So, for this, we have Sendil sir. So, we all have heard when he speaks, especially the statistics part of it and how to take it to the clinic. I think that is where the actual thought process comes into place. And we also have Dr. Akil Kapoor. He's always into clinical trials and he will be the best to share his thoughts. So we will be having each candidate discussing a particular part of the clinical trial. After he presents that, we will try and have an interactive session. This is mainly an interactive session and not a theory class by one person. Anybody has questions can put in the chat box or can raise the hand and interact. So without wasting much time, I would ask the first presenter to take up and share the screen and start presenting the trial. It is our own Indian trial from Sudhir Gupta sir, practice changing trial of carboplatin in triple negative breast cancer neoadjuvant setting. So over to you, Dr. Nihanti, and to proceed the further discussion.
Thank you, Chandrakant sir. So, we have a first candidate, Dr. Syed Nasir. He's a first year DM medical onco student from MNJ Hyderabad. Dr. Syed, you can start and you have 15 minutes to go. Please stick to the time.
Good evening, respected seniors. Today, my topic of presentation in the ISMPO Journal Club presentation is regarding the background and methods. Coming to the name of the title of the article is Addition of Carboplatin to Sequential Taxane Anthracycline Neoadjuvant Chemotherapy in Triple Negative Breast Cancer. It is a phase 3 randomized controlled trial by Dr. Sudeep Gupta et al. Published in American Society of Clinical Oncology on October 20, 2025. Why this trial actually matters? First, it is a first adequately powered phase 3 trial evaluating the platinum addition to the standard taxane anthracycline neoadjuvant chemotherapy in triple negative breast cancer. And it addresses long-standing controversy from phase 2 or phase 3 trials with discordant survival results, as we have seen in the GPAR-62 and brightness trials and CalGB. And it is clinically relevant because platinum increases the toxicity and the cost. And the results directly inform a real world decision making, especially in the low middle income settings, country settings. Coming to the background, as we know that non-metastatic triple negative breast cancer, the treatment usually comprises of surgery, chemotherapy, and the radiotherapy. And recently, the immune checkpoint inhibitors addition has shown to increase the event-free survival and the pathological complete response and OS benefit when added to the anthracycline, cyclophosphamide, taxane, platinum as a part of neoadjuvant chemotherapy. The adequately powered phase 3 studies as a part of neoadjuvant treatment were not available. And coming to the rationale, as you see here, the three trials which were at the around of the 2010, the GPAR-62, which is a phase 2 trial, and similarly the brightness, which was a phase 3 trial, and CalGB. These studies all showed that there is the carboplatin increases the pathological complete response. And if we see in the survival benefits, the GPAR-62 and the brightness study showed that there is a DFS and EFS benefit, but in contrary, the CalGB showed no benefit. And similarly, if we see the GPAR-62 and CalGB had bevacizumab, and in the brightness there was an additional arm of veliparib. So they were not adequately powered. So therefore, the role of the platinum as a part of neoadjuvant treatment in the TNBC has not been definitely proven at the time. And adding the platinum agents can lead to the increased toxicity. So establishing their role was substantial clinical relevance. That was the rationale behind doing this study. The study question was, does...
Sayed, can I stop you for a moment? Sayed, go back to the previous slide, Sayed.
Yes, sir.
Okay, so Dr. Gupta's study also had EFS and DFS as the primary endpoint, correct?
Yes, sir.
So all these studies have already answered the question, isn't it? Why
Yes,
did
sir.
Dr. Gupta have to do another study?
They were underpowered, and the studies were underpowered, and as well as
GB is underpowered. Okay, agreed. But the other two studies, JAPAR 62 and brightness, your
they showed,
is better, very good. You showed survival benefit. DFS and EFS are yes, yes. So if it's yes, yes, we are done, right? So you've changed.
and overall survival was also not it was the overall survival, they were not adequately powered, sir.
So are you saying that if overall survival benefit is not there and only AFS benefit is there, you will not use that intervention? 9 out of 10 interventions that you're using now in oncology is not based on overall survival, right?
Yes.
So why did you, rather, why did poor Dr. Gupta want to waste all his time, money, energy in doing this? Okay, Ali is saying Indian patients' data. We'll come to that in a moment. Okay, so what are the arms in JEPAR 62, Syed Yasser?
There was neoplatin with bevacizumab integration in one arm, and one was like placebo, and one was with carboplatin with bevacizumab, and one was only carboplatin with.
So is that your standard of care or standard practice that you routinely do? Bevacizumab in the neoadjuvant setting?
No, sir.
So instead of adriamycin and cyclophosphamide, what did they do? They did adriamycin and bevacizumab, right? So that's typically your backbone that you would routinely use.
Yes.
Correct? And even the DFS benefit in all of these studies, there was a trend to DFS benefit rather than an actual DFS benefit that was there. Okay.
Yes, sir.
The brightness study, there was something called as a hierarchical design, where only if you have a P that is satisfied in the first criteria, then you go and test the second thing. For example, they will say, if the P value for PCR difference is significant, then I will go and look for EFS and do a proper statistical analysis of that. So when they did a hierarchical testing, they said, if the PCR is better, then I will go and do an EFS P value. So the PCR was not better in the brightness. Okay. So since that was not statistically significant, though numerically the EFS was better, it was not statistically powered because you've used all the P to answer question number one. Clear? You understand?
Yes.
So the arms were not standard. In brightness, based on the hierarchical testing, it was not, the P was not used to say whether the EFS was significant or not. So that's why this question continued to remain relevant. So these studies were actually done around the time that Dr. Gupta would have started his study. Okay? So
Yes.
even though these studies read out, we were still not sure that it added benefit because of all of these reasons.
Yes.
And then CLGB, PCR was better, but by the time when CLGB was first read out, we were all so very enthusiastic about PCR and said PCR is positive, then outcome is good, so we have to use this intervention. But over time, we became wiser. We understood that PCR was not as much as a powerful surrogate for EFS and OS as much as we thought it to be. And so we said, no, CLGB is only showing a PCR benefit. It's not powered to give you an EFS benefit. Also because Japar 62 and CLGB were phase 2 studies. Typically in a phase 2 study, you don't have DFS or EFS as the primary endpoint.
Yes.
Yeah. So because of all these reasons, even though there were studies which showed that platinum could improve the outcome, they were not clear cut in terms of the arms. They were either phase 2 or they were underpowered or the hierarchical testing was not satisfied. So there were multiple reasons. That is why Dr. Gupta's trial became extremely important. You understand? Because this table tells us that the question has been answered. We can close today's journal club and go home for an early dinner. Right, Sayed? But that's not the case. Okay. So when you're reading, so when you're doing an introduction, what should you do? You should say what's the evidence that's there, what are the problems with this evidence, and how is this study going to fill in the gap. These are only 3 slides you should show. Yes.
Yes.
What the evidence is there? What are the problems with this evidence? How is the present study going to fill in the gap?
Yes.
Lovely. So go ahead.
The study question was actually, does the addition of the carboplatin to the sequential taxane anthracycline neoadjuvant chemotherapy in triple negative breast cancer lead to the improvement in the survival? So as the primary point was event-free survival, and the secondary endpoint was overall survival with the PAC-CR. So it was primarily the event-free survival will lead to the event-free survival or not. Coming to the study design, it was phase 3, a randomized trial with 1:1 randomization ratio and open label conducted at a single center, that is Tata Memorial Center, India, Mumbai. And the population was women 18 to 70 years who are triple negative breast cancer and who are either large operable, which is defined as clinically T3 or N1, or locally advanced, that is clinically T4, N2 to N3. At the time of the staging was AJCC's 7th edition, and the sample size was actually 720 were randomized, and who were analyzed was 717, that is modified intention to treat, because the 3 patients became non-eligible. One due to the one who withdrew the consent, and another one due to ventricular arrhythmia, and one underwent the previous treatment. And the stratification was done here according to the clinical stage and the menopausal status. And this menopausal status stratification were not done in the previous studies. So that adds another point to this study. Coming to the treatment arm, in the control arm,
Sayed, let's go back to your previous slide, Sayed.
yes, sir.
Right? So let's look at some of these points and try to understand what they all mean. So let's understand what is stratification. Chandrakant will explain what stratification is because he's done a nice, picture on what is stratification and why is it important in randomized trials. So tell us what is stratification.
So basically, it's a randomized trial. So when you randomize patient, uh, there can be an unequal distribution. If you just toss a coin, a particular patient can fall into either of the arms. So if I keep tossing every time, so let's say a T4 keeps falling into a carboplatin arm, it doesn't fall into a control arm. So, but if you stratify that, if I have four T4s, those patients, so two of them will go to, uh, a group of T4s will be a single one, and uh, I will randomize those four T4s to either of the arms. So that is, I am actually following a randomization rule, but with the caveat that I am grouping each uh, like stage and then premenopausal, postmenopausal status. So there is a uh, there is a rule which I am following in randomization. So this is what I understood. Tanvir sir, you can explain it properly.
Yeah,
You can articulate it properly.
decide on clinical stage and menopausal status to stratify side. I can say, use whether you came from North India or South India as a stratification factor. I'm saying so they have used clinical stage and menopausal status stratification. Correct?
Yes. Yes.
I am asking you the question, why did they not think about North India versus South India as stratification factor?
It might not be clinically that relevant like in breast
Very good,
cancer.
very good, excellent. So you're coming to the point. So why did they choose these two?
Like the stage versus like the treatment and menopausal interaction with the treatment might interfere, like young versus old,
Very good.
and they are susceptible for the HRD and as well as immunogenic.
No. Don't get into HRD and all of those. Let's keep it to the first half of your sentence only. Right?
Yes,
The
sir.
first half of your sentence was that it can impact the results. Correct? Is that what you?
Yes.
Correct.
Yes, sir.
So very good. So stratification factors are factors which can impact outcomes. There are some strong factors which are bound to impact outcomes, which you certainly don't want to be unequally distributed between these arms. Correct?
Yes, sir.
So why do you randomize? When you randomize, you want to make sure, somebody is writing to make sure that confounding factors are equally present. That's the correct answer. So when you're randomizing, you're making sure that patients with all kinds of characteristics are equally distributed between the arms so that the likelihood of there being an imbalance in these factors which can impact the results are minimized. You understand? I made a very long sentence. I said, when there are some factors which can impact the outcome very strongly, you want to make sure that these factors are equally balanced between the arms. So your point was correct. It's just that somebody said that in a more technical way. So
Responding back.
very, very important. So if it's not equally distributed, it will end up confounding for sure. Menopausal status, very important. If you don't equally distribute it, it's going to confound your results for sure. So they chose these two very important. So usually there are between 3 to maximum of 5 stratification factors that they would choose when they randomize patients.
Yes, sir.
So this is to make sure that the most important factors that can confound or impact the results of your treatment are definitely equally distributed between the arms. So when you randomize, you are making sure that bias secondary to both known and unknown factors. See, known factors, you are looking for it and then saying one arm has got more, one arm has got less. But there are some unknowns which you really can't do anything about. So when you're randomizing, you're making sure that both the known factors and unknown factors are equally distributed between the test arm and the treatment arm, or the standard arm and the experimental arm.
Yes.
Understood? So that is the purpose of stratification.
Yes.
Very good. So,
Yes.
so we've said phase 3, we said, why is it randomized? We won't go into what is 1:1, when will they do 2:1. That's not the statistics class. We'll do it some other day. Single center, standard, the age criteria, adults, triple negative cancer as defined by ER, PR, HER2, 0. Right? HER2 is, of course, the standard definition of HER2 negative. Don't bother about low and ultra low and all that here. So even if it is 1% positive ER or PR, you can't be in the study.
Yes.
Understood? So that's very important. And then the patients who went in randomized, you said modified intent to treat. We said, what is stratification factor?
Yes,
We
sir.
do subgroup analysis later, stratification versus subgroup analysis. Does it mean that if it is stratified, it is powered or not? We'll come to that a little later. Understood? Nihanti, are we
Yes.
time?
We have only 5 minutes, sir.
Yeah, 5 minutes. Okay, that's 5 long minutes. Don't worry. Go ahead. Go ahead, Syed.
Now, so in the control arm, the paclitaxel was given 100 mg per meter square weekly for 8 weeks, 1 hour infusion. Again, say that 8 weeks, not 12 weeks here. Presently, we are using the 12 weeks. Here, it was used 8 weeks. And the anthracycline.
Oh, Syed,
Sir?
what is the dose when you give it 12 weeks?
80 mg per meter square.
Correct. So it's 80 mg per meter square, not 100 if you're using it for 12 weeks, right? So
Yes,
they
sir.
calculated the cumulative dose, which is the same.
In the platinum, then followed by anthracycline plus cyclophosphamide, that is 3 weekly for 4 cycles. And in the platinum, the paclitaxel was given 100 mg per meter square weekly for 8 weeks with the addition of the carboplatin, that is area under the curve, 2 weekly for 8 weeks. And followed by same anthracycline plus cyclophosphamide. And the patients were taken up for the standard surgery, that is, if they were eligible for mastectomy or if they were eligible for the breast conservative surgery, they were taken within 6 weeks post the last cycle of the chemotherapy and then followed by the radiotherapy. The assessment was done.
Okay, Syed, pause for a moment. Quickly, go back to the previous slide. How is this treatment different from what you do today? Tell me 1, 2, 3, 4 quickly, and then we move on to the next section, results. So you already pointed out one, 8 weeks versus 12 weeks.
8 week versus 12. One is according to Keynote 522.
No immunotherapy in this. Over. Next.
Carboplatin area under the curve 1.5 or 4 week AUC 4 or 5 we use for 12 weeks.
If it is 3 weekly, 1.5. If it is Keynote 522.
Yes, sir.
Okay, that's over. Very good. Then one more point.
They use some epirubicin also, sir, in this.
Fine, that is okay. A lot of us use epirubicin, but the point is there is anthracycline. Next. What happens to patients post-surgery these days? You look at the pathology.
Capecitabine, yes, sir.
Go ahead.
Capecitabine or adjuvant Ibraca positive olaparib.
Very good. So the differences are 1, 8 weeks versus 12 weeks.
Yes, sir.
Number 2, therapy yes versus no. Number 3, the carboplatin dose. Number 4, this trial did not incorporate CreateX or the adjuvant BRCA positive study as part of its treatment, which I think was correct because at the time that they conceived this study, all these things were not there.
Yes, sir.
You can always argue saying they should have changed it over time, but I think you keep it clean because you don't want to have multiple cohorts of patients when you finally analyze. So it's absolutely fine not to do adjuvant capecitabine in patients who have not had a PCR. Okay, very good. So somebody is saying reverse sequencing of chemotherapy regimen. Say you have something to say about that. So
Because we probably proposed AC followed by Taxol was used, but reversing was thinking immune immune induced cell death could be with the carboplatin and
no,
Taxol.
that was not the answer. So there were some studies that were done which showed, not carboplatin based studies. There were some studies, FEC followed by T. When I was a student, we used to do a lot of FEC. So the FEC T versus T FEC. There's a study which is a randomized phase 2 study which showed that instead of doing anthracycline followed by the taxane, if you did the taxane followed by the anthracycline, the outcomes were better. And there were some smaller studies where reversing the sequence, doing taxane first versus anthracycline later, showed a better pathological complete response. So, because of this reason, in fact, it's there in the discussion of Dr. Gupta's study itself. That's the reason why they reversed the sequence. Yes, that's a good point. But the reason for reversing the sequence is not much to do with the immune environment. It's more to do with some previous results which kind of pointed out to the fact that if you use the taxane first, your outcomes are likely to be better.
I'm so sorry, sir.
No, you don't have to feel sorry, Nihanti.
Yeah.
You can just say stop and then we'll stop.
No, because Dr. Syed is first year, we still have two final year students, sir.
Okay, so we'll then discuss with the final year students.
Yeah.
Syed, good job. So we will now move on to the next section because Nihanti has said move.
So we can move to the next section. It's the results and interpretation. It's
Right.
by Dr. Rupam. Sir, he's a final year student, so he'll be more well versed with the treatment protocol. Thank you, Dr. Syed. Dr. Rupam, are you there? Dr. Rupam, you're not audible. So you can say anything if you want to, like, because only an initial part of the trial has been discussed, sir. In the meantime, Dr. Rupam would become online.
Good evening, sir. My respected teachers.
Sure.
You can make
Is my slides visible?
Yeah, you can make it.
Slideshow.
Yeah.
Full screen.
Rupam, your slides are visible. Please make it full screen, no? So in the meantime, you want to give any comment to the only the brief introduction part you can, sir.
So, as I said,
Is it full screen now?
yeah, it's full screen.
Yeah.
So, as I said, Syed, I just want to reiterate that point. So, whether you write an introduction or you talk about 3 points, what's the evidence? What are the gaps? How are you filling it up? So, those are the three questions. So, do it. Who is doing the journal club next time? Do it that way. Go ahead, Rupam.
So this trial design is already discussed, and I am directly going to dissect the result of this study. So this is the abstract result. So we have seen that 720 patients were randomized, 717 included in the modified intention to treat analysis. Platinum arm, 361 patients were in platinum arm and 356 patients in control arms. So baseline arms based on basis of baseline characteristics, arms were well balanced for age, menopausal status, family history of cancer, clinical tumor size, and clinical nodal status. And disease burden, as per disease burden, this was a high risk TNBC population. So 60.3% had clinically T4 and was clinically N2 N3 disease. 70.7% has more than 5 centimeter size tumors, and 88.8% were clinically node positive. So if we see the event-free survival, the results, so the median follow-up time was 67 months, and the total event-free survival events were 242. In platinum arm, it is 111, and control arm, it is 131. Hazard ratio was 0.8, but p-value was 0.08 unstratified and 0.06 stratified. So we can interpret that there is 20% relative reduction in event-free survival. However, the confidence interval crosses 1 and the p-value does not meet in the predefined threshold. So primary endpoint was not statistically met. So if we see the curve, it is already described. That is in curve A, this hazard ratio was 0.7, but p-value was not statistically significant. But in the next, I will speak about this premenopausal and postmenopausal groups. So in premenopausal groups, it is statistically significant. So p-value is 0.03 and hazard ratio is 0.605. And in the postmenopausal group, this event-free survival, it is not statistically significant. P-value is 0.386 and hazard ratio is 1.193. This is the interpretation. We can see that this subgroup finding for premenopausal women, it is statistically significant, clinically meaningful, and consistent with OS and PCR result. And for postmenopausal group, there is no evidence of benefit from carboplatin, and this supports lack of efficacy in postmenopausal TNBC on the basis of event-free survival, which was our primary endpoint. Next, if we see this forest plot that this subgroup analysis is showing, this treatment effect was examined across this menopausal status, age, menopausal status, family history, tumor size, clinical stage, and nodal status. We can see that this overall event-free survival results, menopausal status and age show statistically significant interaction, unlike other subgroups, and this makes mask a strong, consistent benefits confined to premenopausal and patients only, and less than 50 years of the age group patients. Next, this OS results and interpretation. If we see that total deaths were 215 in platinum arm, it was 94, in control arm it was 121, and the median follow-up duration was 67 months. Overall OS for 5-year OS was hazard ratio was 0.74, and p-value is statistically significant. We can say that addition of carboplatin leads to 26% relative reduction in risk of death and absolute OS benefit of 7.6% at 5 years. This is a rare and important finding in neoadjuvant breast cancer trials. If we see the curves, we can see that for the entire population, OS is entire population OS in premenopausal patients in platinum and control arm, and then this is statistically significant, that is p-value is 0.02, and the hazard ratio is 0.57. And for premenopausal group, it is it is for premenopausal group, it is it is statistically significant, and for postmenopausal group, it is not statistically significant. P-value is 0.772. And this is the OS in the intention to treat population in the platinum and control arm. We can see here that is p-value is 0.02, that is statistically significant, and hazard ratio is 0.74. Then this OS by menopausal status. We have already discussed, that is for premenopausal, because this is there is 43% relative reduction in the mortality. Absolute OS benefit is there, 13 to 14%, and large, durable, and clinically compelling effect was present. This is consistent with EFS benefit and pathological complete response improvement. This strongly suggests a true biological effect, whereas for postmenopausal women, there is no OS benefit, and survival curves essentially overlap, confirms lack of efficacy of platinum in this subgroup. And this is statistically significant interaction between treatment and menopausal status and age seen for both event-free survival and overall survival. And benefit is confined to premenopausal and younger patients. And this is why this matters, because this is not a chance subgroup. Menopausal status was a stratification factor, as we have as Sir has discussed already, and baseline characteristics were very much balanced. So consistency across endpoints strengthens the credibility of this phase 3 trial. And if we see the forest plot, we have already discussed, as per the discussion, for the less than equal to 50 years and for premenopausal group of the patients in these subgroups, this is statistically significant, and hazard ratio is significantly good. Next we will discuss the distance disease-free survival, and this trend towards improved distance control did not reach statistical significance because p is p-value is 0.064, and this directionally consistent with OS benefit and suggests platinum may reduce distant relapse, but study was underpowered for distant disease-free survival. As we have discussed, for event-free survival, events which was analyzed, it was local recurrence, regional recurrence, distant mets, progression during NSCT, brain mets, and death. And there is also no expected toxicity related deaths. So this supports oncological plausibility of OS benefit. So this is the chart showing pathological complete response to neoadjuvant therapy. So if we dissect, that is PCR rate, yeah, was in platinum arm, it is 54.5%, control arm, it is 14.3%, absolute increase in 14%. So, and this is also highly statistically significant. So we can say carboplatin produce a substantial improvement in tumor eradication at surgery, confirms strong chemosensitizing effect of platinum in TNBC, and this is magnitude of PCR gain is also clinically meaningful. And for if we dissect as per subgroups, then for premenopausal women, p-value is less than 0.01. That is very much significant and very large and robust improvement in PCR rate. Effect size mirrors improvement seen in EFS and OS. But in postmenopausal group, p-value is not significant. No meaningful PCR benefit from platinum confirms lack of efficacy in this subgroup. Supports treatment de-escalation in older and postmenopausal TNBC. So you can say that carboplatin markedly increases PCR rates in TNBC, but these benefits and its translation into improved survival is confined to premenopausal patients, reinforcing the concept of biologically selective treatment intensification. So we can say that prognostic values of PCR, achieving PCR was associated with improved EFS and improved OS. This was true for all patients, premenopausal and postmenopausal. And even though platinum did not increase PCR in postmenopausal women, but PCR remains highly prognostic for all the groups. And this distinguishes that the predictive value of platinum and prognostic value of pathological complete response. So if we see the toxicity of neoadjuvant chemotherapy in platinum and control arm, so overall tolerability, neoadjuvant chemotherapy was well tolerated in both arms. Importantly, the addition of carboplatin did not compromise treatment delivery, but higher rates of hematological toxicity in the platinum arm was there. That is neutropenia, anemia, thrombocytopenia. Thrombocytopenia was more with platinum arm and expected and mechanistically consistent in platinum use. And non-hematological toxicity like neuropathy, cardiac toxicity, renal and hepatic toxicity, no clinically meaningful increase in all these toxicities. Serious adverse events were comparable between both arms. And treatment compliance, this key strength, and a high and similar proportion of patients in both arms completed all the 8 planned weekly dose, and this included postmenopausal or older patients also. So, why this is important? Because anthracycline phase.
Rupam, why is this clinically important? We'll come to the interpretation in the discussion section. So, what I want you to do is go back to the slide where you showed the results of the abstract. Go back. Your first slide. Yes. Okay. So,
Yes.
slowly read the results and then we will go through these numbers one by one. Okay.
Okay. So, of 720 patients randomly assigned between April 2010 and January 2020, 717 patients, in which platinum arm 361 and control arm 356 were included in modified intention to treat analysis
Very good.
at median
At
follow-up of
67.6 months. So,
6
first,
months.
what is the median follow-up that you would like to see in a triple negative breast cancer study?
Mm,
1 year, 2 years, 5 years, 10 years.
Ideally, it should be, sir, more than 5 years.
Why is it that you
Um,
need more than 5 years for EFS? So Ali is saying at least 3 years. You agree with him? You don't agree with him?
mm,
But he's made
Sir,
it correct.
I'm not sure about exact sir number, but it should be at least 5 years, I think.
So then you can't say it should be, right? There should be some reason for them to say median follow-up is 67.6 months. That's just over 5 years, correct?
Mhm.
So Ali is partly correct. We would be happy to see at least 3 years because we know that the majority of recurrences in patients with triple negative cancer happens in the first 2 to 3 years, right? It's not that it
Yes,
does
sir.
not happen later. It's just it happens with somebody is.
Mm.
Yeah. So it's not that there are no relapses after 3 years, Rupa. It's just that the majority of relapses happen by then. And all these
Yes.
trials are event driven. That means the trial becomes more robust in terms of its statistical analysis if you have more events that happen. Beyond year 3, the likelihood of large volume of events happening is less, it's not zero. Okay?
Okay, sir.
While
Okay,
we'll
sir.
be happy if 5 years are there, we are reasonably okay if at least 3 years of follow-up are there for a triple negative cancer study. But for an ER
Okay, sir.
positive cancer study, we'd like to see longer follow-up because patients continue to relapse for a prolonged period of time. So that's the importance of at a median follow-up 67.6 months. But when they reported this study, it was more than 10 years after they first started the study.
Okay, sir.
Go ahead, read the rest of it.
Okay,
At
sir.
a median follow-up of 67.6 months, there were some
In platinum, there were 111 and 131 EFS events. Hazard ratio was 0.8 and 95% confidence interval 0.62 to 1.03.
Okay.
Two-sided unstratified p-value.
Slow. Rupam, slowly, I'm going to dissect every word in this result now. So I'm going to
Okay, sir.
talk
Okay, sir.
about every bracket and every word now. Okay, so don't run through it. So 0.8, 0.60 to 1.03. So you nicely said that since the upper limit is beyond 1, it is not significant. Agreed. And then it says some two-sided unstratified P. Correct? What are these two sides? And what is this stratified?
Uh, uh, Sir, sorry, can you repeat, please?
What is this two?
Acha, two-sided unstratified. Okay. Um,
For the confusion. It didn't provide a
What is this two-sided and what is this unstratified?
for premenopausal and
We have not
uh,
menopausal business there. Just read that line and then does it say premenopausal, postmenopausal?
sorry, sir,
Correct.
I don't know.
Is there a possibility? Did you ever think about the fact that platinum could produce a detriment? Did you ever think about it like that? We always assume that
Hmm.
Muthu is coming close to the answer. Very good. Lovely Muthu, whoever you are. Good answer. So, Rupam,
Hmm.
there's something called as a null hypothesis and there is something called as an alternate hypothesis.
Alternative.
So, null hypothesis is that platinum is as good. I mean, platinum does not add any benefit. That is null hypothesis. The alternate generally that we assume is that platinum is going to produce betterment. But did we ever think about the fact that platinum can produce detriment?
Okay, no, sir.
No.
That's it.
Because the hazard ratio had been 1.2 for this event-free survival, right?
Mm-hmm.
If you applied a p-value there, unless you have statistically done the calculation to make sure that if there is a detriment also, my alpha is going to give me the answer to that question. Alpha is the likelihood of the trial being falsely positive. The result that you're showing is falsely positive. That is alpha. Correct?
Okay, sir.
So
Yes, sir.
we are saying 0.05, which means we are likely or we are happy to take a 5% chance of this result being falsely positive. So when they design, you can either design on one side, which is only having a positive result, or you can have negative also. So when you're doing a two-sided value, it means that your trial has been designed to show if this is statistically detrimental also.
Okay.
What Muthu has written tested difference in either direction. The direction is betterment, detriment. Understood? So that is
Okay, sir.
two-sided, or some people also call it as a two-tailed p-value.
Okay, sir.
Unstratified. We do two-sided analysis not in all the studies, Ali, but in majority of the studies, the alpha is, has been distributed to show it in both directions, but not always. Or at least they don't express the results that way. Okay, that's important. Now, it also says unstratified. So again, Muthu has written, but does not account for the stratification factor. So it's just calculated the p-value based on a log rank test for the whole group. It is not accounted for possible confounding factors like age, menopausal status, and all of those things. Understood? Did you or not?
Okay,
Rupam,
sir.
right? No, you should say yes or no, not okay.
Yes, sir. Yes, sir.
Okay?
Yes, sir.
Very good. Excellent. So we are looking at two-sided or two-tailed p-value. We are talking about an unstratified p-value. We will do a stratified p-value when you come to that subgroup analysis.
Okay, sir. Yes, sir.
Very good. So let's continue to read. 5-year EFS of 70.7% and 64.1 respectively. And that was not significant, correct? And then it showed some event
Yes, sir.
ratio of 0.74, a nominal P of 0.029. So is that significant?
Yes, sir.
0.0,
0.029 is significant.
we take 0.05 as significant. So let's not get into the intricacy of what's the difference between a nominal and an unstratified. Many times they are interchangeably used, but they are not the same. Again, let's not waste time on p-value today, maybe another day. So in premenopausal women,
Okay.
the hazard ratio was 0.61. OS hazard ratio was 0.57. Both of these were statistically significant. In postmenopausal women, it was 1.19. So, what is the meaning of this 1.19 EFS, Rupa? So, you said if it is 0.08, see, somebody, Ronak is saying, is it harmful? So, tell me what is 1.19 mean? So, you said if it is 0.8, you said there is a 20% risk reduction for having an event. Correct or not?
Hmm. Hmm, hmm, hmm.
So if it is 1.19, what does it mean?
It is 19% more chance of causing that event.
So,
Um,
so then Dr. Gupta should have concluded that in premenopausal women it is beneficial, in postmenopausal women it is detrimental. Yes or no?
yes, sir.
Aisha is saying 19% more chance of the event to occur. My goodness, we are stuck somewhere now. Rupam? Okay, let's finish this and then we'll go to that forest plot. So then it goes on to say that there was a statistically significant interaction between study intervention and menopausal status for EFS and OS, with a benefit for adding platinum in premenopausal but not in postmenopausal. Okay,
Hmm.
that means it's benefiting premenopausal, not postmenopausal. So go to the forest plot for event-free survival now. Yes, so this is subgroup analysis. This is event-free survival.
Yes, sir.
Very good. So, why did Dr. Gupta conclude that there was only benefit in premenopausal or less than 50 and not a detriment in postmenopausal women?
Well, if we see the confidence interval, then it is for the postmenopausal women, it is from 0.8 to 1.780.
Okay.
So we can see that the range of the patients both lies in platinum better and control better, um, in two parts. So it cannot be concluded like that it is detrimental for postmenopausal group. But in case of premenopausal group, it is clearly seen that entire population, that is horizontal line, is in the platinum better part of the side of the forest plot. So it is beneficial for premenopausal group.
You are almost correct. So, clearly, for the premenopausal, so first is have they, so this is a very nicely done forest plot. You don't see this very commonly, even in the best of journals, including New England Journal of Medicine. you see that they have only tested for a limited number of variables. They have not tested for 25 variables. They have just tested for 1, 2, 3, 4, 5, 6 variables. So the probability that you will find a falsely positive subgroup analysis keeps increasing as you test more variables. Okay? So this is in general. They have nicely represented platinum, control, 5-year event-free survival, and then there is hazard ratio. Very importantly, they have given something called as a p-value for interaction on the right side. Did you see that?
Mhm. Yes, sir.
So, what is the p-value for interaction, say, for menopausal status and age?
For menopausal status, it is 0.01, and for age, it is 0.01. Both 0.01.
So,
So
for the others?
for others, it is more. It is 0.8, 0.19, 0.469.
So, are they
So
significant? You can also come to another conclusion.
these are not significant.
Look at clinical stage. For LABC, the point estimate is to the left side. The confidence interval is also within the left side only, on the left side of unity. Correct?
Yes, sir. Correct, sir.
But for patients with operable breast cancer, T1 to 3, N0, N1, you see that the point estimate is 1.
Hmm.
So why did we not come to the conclusion that it benefits only LABC patients?
For the same reason, sir.
And
Okay, so for this p-value for interaction has some role, I think.
so no. So I think so. Whenever you see a forest plot, keep this forest plot in your mind. This is a superbly represented forest plot. Again, I'm saying,
Hmm.
when I discuss forest plots, this is the example of an ideal forest plot that I use. So you see that the p-value for interaction is significant only for variables 1 and 2, which is age and menopausal status. Okay.
Hmm.
So usually p-value interaction in a forest plot for subgroup analysis, we don't accept a value of 0.05. That's generally not the accepted level. Okay. So there is
Okay.
something called as a Bonferroni correction that you do to find out what is the p-value at which you will call this interaction as significant, which is not there in the paper in the statistical methods, but I assume that they have done that calculation and it is significant.
Okay, sir.
Yeah. So this p-value is significant only for age and menopausal status, but not for any other variable, even though you're seeing that some of these variables, the benefit seems to be more, the benefit seems to be less. Yeah. Second, not concluding that there is detriment for postmenopausal women because of partly the reason that you said that the lower limit of the confidence interval is to the left of unity.
Left of it.
Is totally to the right side or to the right of unity, we can then conclude that there is something called as heterogeneity. So when you call it as heterogeneity, then you say that this interaction is negative for that particular subgroup, which is postmenopausal women in this case. Since the lower limit is crossing the unity line and is to the left, and it's overlapping with the upper limit of confidence interval for the premenopausal and the less than 50, we can call this as inconclusive. So we cannot say that there is detriment in postmenopausal women. We can say that this interaction or whether this benefit or not is inconclusive for women who are postmenopausal. You understand?
Yes.
So it can be either conclusive, inconclusive, or depending upon the p-value. So here, interaction P is significant. So you're saying that it benefits one group, it does not benefit the other group. And remember that the p-value for significance here, this is called a stratified p-value here because you've cut it down to those stratification factors. Understood? So there
Yes,
you saw a non-stratified p-value. Here you're seeing a stratified p-value. Generally, for a stratified p-value, the p of 0.05 is not adequate to show significance. Understood? So it's much lower than the 0.05. Here it's 0.01 here.
Okay, sir.
So that is number two. Number three, the benefit of carboplatin in postmenopausal women can at best be called inconclusive based on this forest plot. Can we categorically say detriment? No. Can we categorically say there is no benefit also? Again, probably not. So this forest plot for postmenopausal women, this forest plot, when you talk about benefit of carboplatin for postmenopausal women, we will call it inconclusive, not beneficial. But, sometimes based on these values, we tend to say there is no benefit also, which is not totally wrong, but the appropriate thing would be inconclusive.
Apologies, we need to save the time and
We'll move on. Okay, so understood. So you've learned what is a stratified p-value. You've learned what is a one-tailed and a two-tailed p-value, right? And you've now reasonably understood how to look at a forest plot. What are the parts of the forest plot? Looked at why that p-value for interaction is important, and this is a stratified p-value. Clear?
Yes, sir.
These are the important things that you should see, and this is how you should properly and adequately represent a forest plot.
Okay, sir.
Understood, Rupam? So the next to a journal club, you will go and look at all of these.
Yes, sir. Yes.
Very good. So now we can move on to discussion, Nihanti.
Yes, sir. So the final speaker is Dr. Shubhra, sir. She's going to deal on topic of critical appraisal, clinical implication, and comparison with the existing data. Dr. Shubhra, are you there?
Yes, ma'am. Am I audible?
Yes, you're audible. Please make it full screen.
Yes, ma'am. Good evening, sir. Good evening, everyone. We'll proceed with the discussion part of the presentation. Coming to the critical interpretation of the efficacy outcomes, the event-free survival, which was the primary endpoint in the study, in the modified intention to treat population, the addition of carboplatin actually did not achieve a statistically significant improvement in the EFS. The EFS events in the carboplatin arm were 30% compared to 36.8% in the control arm, with an absolute benefit of approximately 6%. The hazard ratio being 0.8, but the hazard ratio was crossing infinity. The confidence in the
Can I interrupt for a moment? Let's not get into the data points again. We've discussed enough on the data points. I want you to tell me, is this applicable in practice? Yes, no. And are there reasons why we should be using it in premenopausal women selectively and not use it in postmenopausal women? What would you do in your practice? I think that's what you should talk about in the discussion. Let's not go through all these points all over again.
Yes, sir. So the primary endpoint of the study, which was EFS in the modified intention in the ITT population, actually failed to meet the statistical significance. So the strength of the causal inference for EFS in the overall population is limited. So by strict hierarchical interpretation, that is first we need to look at the primary endpoint and the primary analysis, which is negative. It renders the trial negative. But as we come forward, I would like to point out this plot of the EFS.
So, sorry to interrupt. When you are talking about hierarchical, it means something entirely different. So this is not a hierarchical testing that was employed here, Shubhra. Hierarchical means you use a p-value for one endpoint. You only go to the next endpoint and test it statistically if the first endpoint is met and is statistically significant. If it was hierarchical testing, they should not have done any further testing. So this was not a hierarchical design. Understood?
Yes, sir. So coming to the EFS curves, the Kaplan-Meier survival curves of EFS in the median ITT population and in the premenopausal group, we can see that the curves separated more in the premenopausal group more than the overall population. However, during the initial first 12 months, we can see that there was a sharp drop in the EFS across both the populations, the entire population, and in both the arms, which was one of the criticism of the study, that there was an early drop in the event-free survival in both the arms. This could be explained probably by the fact that there is a certain proportion of the disease which is inherently chemorefractory in biology. They do not respond to chemotherapy and it does not indicate a loss of treatment effect, but it may have overall diluted the long-term EFS benefit, and hence we could not achieve a significant EFS benefit, and the confidence interval crossed unity. Coming to the overall survival, which was the key secondary endpoint in the study.
Go on, Shubhra. So again, you're going through the same data points. I don't want you to go through the data points. Okay, so let me ask you some questions then. Why did it benefit premenopausal women and not postmenopausal women? So that's the crux of this discussion, right?
Yes, sir. So if we come to the basic biology of a triple negative breast cancer, it is different in the two subgroups, premenopausal and the postmenopausal, which is also correlated with the age being less than 60 and more than 60 approximately. The biology in the premenopausal subgroup is more basal-like, so it behaves like a typical TNBC, whereas the histology in a postmenopausal group is more of luminal type. So it behaves more like a hormone positive despite being triple negative. And the basal subtype, the basal type is more chemoresponsive, so is more chemosensitive. Also, the premenopausal age.
There are some reasons, isn't it, Shubhra? So they have spoken about the type, they've spoken about, the basal versus the luminal subtype, and then the microenvironment, your responsiveness to, carboplatin and so on and so forth. So Padmaj is saying, do you think it is due to amenorrhea caused by chemo in premenopausal patients? So do you want to take that question, Shubhra?
So partly there is a point that the amenorrhea actually which is caused by the chemotherapy. Sir, I'm not sure about this.
Where is amenorrhea important? Is it important in ER positive disease or ER negative disease?
What an ER positive disease?
Lovely. So did Dr. Gupta include ER positive disease in his trial?
No, sir, they were
He
not
did
included.
include ER low patients also in his trial, right? It was a very clean trial,
Yes, sir.
right? So amenorrhea caused by chemotherapy probably is not one of the reasons why this can happen. So they have mentioned so many of these reasons. Is there any pointer in this study to say that that might actually be the reason? That carboplatin effect might actually be different in these patients? Did any one of you go and read the supplement of this trial, Shubhra? Did you go and look at the supplement?
I had a look at the supplement, sir, but
What did you look at in the supplement?
so the trial design, the protocols. Mhm.
Trial design is not there in the supplement, correct? So, did you look at the PCR rates in the supplement?
Yes, sir, the
What is the
pathological
PCR for premenopausal women, postmenopausal women, and the test
Yes, sir. So the pathological complete response is a surrogate endpoint to the long-term survival outcomes. Overall, there was a gain in the pathological CR rates by approximately 14.2%, which was statistically significant. And when we go to the subgroup breakdown, the majority of this gain was driven by the premenopausal subgroup, with an absolute gain of over 20%. And in the postmenopausal women, only a 5% gain was seen in the pathological complete response. So one of the strengths of the study is that there is internal consistency. That the population, the premenopausal population, which actually achieved better PCR gains, they also here the PCR improvement also reflected better EFS and OS survival.
Okay, so if you look at the PCRs in the premenopausal arm for the non-carboplatin arm,
Yes,
the postmenopausal non-carboplatin arm, you see that they're the same 40.6 and 39.9, correct?
yes, sir.
So it tells you that the milieu in premenopausal women in some way seems to be benefiting the activity of carboplatin.
Oh, yes,
That's the point I'm trying to make here.
yes,
Let's
sir.
say that if in premenopausal women, the milieu is in general making it responsive to chemotherapy, what we should have seen is that in the non-carboplatin arm also the PCR should have been higher, correct? It's a little complicated, right?
Yes, sir.
Yes. So, in the premenopausal group, you see that in patients who have not taken carboplatin, the PCR is 40%, correct? 40.6%.
Yes, sir.
In postmenopausal women, it's 39.9%, almost same 40%. Yes.
Yes, sir.
Yes. So, if we say that in general, the milieu seems to be favorable in the premenopausal group to get more PCRs, then we should find that in the premenopausal women, the non-carboplatin group should have a higher PCR than the 40%. Okay, don't bother, don't bother. Maybe, this is very difficult to explain online. So maybe sometime when we have a chance to meet,
No, sir, it's understandable, sir. You can continue.
you can't,
Or other-
you are able to understand.
Not only for me, everyone, sir. Yeah.
Argument that we can make here is that
No.
the premenopausal subject.
The point is some of these hypotheses that Dr. Gupta and group have generated seem to be true, though we don't have biological analysis to substantiate that from this PCR value, right? So you may say the microenvironment is robust, there's no immune cells. So all this should benefit the non-carboplatin patients also.
But the germline BRCA population,
And BRCA population will respond well to anthracycline, to cyclophosphamide, to carboplatin. They will respond well to everything, Shubhra, not carboplatin only.
yes,
Understood? So there is some substance in what they are saying based on the PCRs that we are seeing. Okay, so we are 8-5, so we need to quickly conclude now. Chandrakant, any points that you want to make, Chandrakant? So that then I can, don't bother about the SWOT, Subra. We are running short of time. So we will conclude. Chandrakant, go ahead.
So I think, sir, I think you dissected all important points. So one point which I want to, which I would request you to highlight also is, so this trial's primary endpoint is EFS,
Correct?
and it is negative statistically.
Correct?
But the overall survival is a secondary endpoint and it is positive. The trial is basically powered for EFS, but not for overall survival. So this is basically a negative trial
Correct.
statistically. But still, this is practice changing for us. This is biologically relevant for us. So so there are some trials where we say statistics is negative, we do not follow it. But here, statistics EFS is negative, but still we take overall survival is positive, which is not powered, and we consider it as practice changing. So why in this trial we consider as practice changing? So this is one which I want to.
So I thought you were going to ask one more question. No.
No, that's it, sir.
I think you had partially answered that in your analysis that you had put up in our groups today, Chandrakant, because the event rate that was necessary for EFS was not really met. They could have actually waited for a longer period of time to get more events in order to see if it will become statistically significant. But I think it clearly in the discussion says that they decided to stop and do the analysis right away because they didn't see much substance in waiting for a longer period of time to see if more events would accrue. So that's the reason why the EFS is not significant. Now, why is the overall survival significant? I think patients who have an event seem to die very quickly. They don't seem to really survive long enough. So you're getting, deaths as soon as patients probably have an event. So the survival probably seems to be better. Is statistically significant is the only way that I can think. Now, the other reason why I think is because if you look at the interaction P, the benefit seems to be almost driven by the premenopausal women. Why are we accepting this hypothesis? We are accepting this hypothesis because the p value in the subgroup for both event-free survival and overall survival are significant. So if that significance had not been reached, then we would have clearly said, okay, this is a negative study. This is not a practice-changing study. So we are accepting this primarily because we believe that the events are more in the premenopausal group. The deaths are more in the premenopausal group. So the premenopausal group numbers seem to be driving the intent to treat. The postmenopausals seem to be pulling it back. And so their conclusion clearly is that this is an intervention that is not for everybody. It is only for premenopausal women. Suppose they had said, since the overall survival benefit is there for all women, let us use it in all women, then we would have said that's an improper conclusion. Dr. Gupta has very nicely and clearly, correctly concluded saying there is benefit. This benefit is driven by the premenopausal group. So we should use this intervention in the premenopausal group only. Whether there is benefit in the postmenopausal group or not is something that we don't know. This is important to answer in another study, is what he has said. But we are not going to do that another study. So we need to, move forward based on the analysis that they have done. So this is my, explanation for, why we are calling this practice changing in spite of the primary endpoint being negative.
Perfect, sir. Done.
So then, if people are all confused, never mind. So we will just quickly run through in practice in the exam. What do you do? In the exam, neoadjuvant chemotherapy or carboplatin is used in the neoadjuvant setting for patients who have a tumor that is 2 centimeter or more. Okay, so that's a T2 tumor. That's where, if you're using neoadjuvant therapy, which is what we would use in all triple negative patients, there we would use carboplatin. There are situations in the T1C where some people think neoadjuvant can be used. In such situations, we will not use carboplatin because that was not included in these studies. So if it is T2 above, neoadjuvant therapy for triple negative patients, we will use carboplatin as part of that. If you're using an immune checkpoint inhibitor, then definitely you will add carboplatin as part of that, because the Keynote 522 had carboplatin as part of its trial design. So for the exam, if you know that much, it's good. In Dr. Gupta's study, they used 8 weeks. Typically in practice, we kind of follow the 522 rather than the 8 week. So in 522, the carboplatin dose is 1.5 AUC. If you're using 3 weekly, it's okay to use. Then the AUC is 5 there. The paclitaxel dose is 100 if you're using Dr. Gupta's regimen of 8 weeks, and it's 80 per meter square if you're using the weekly for 12 weeks. Because the immune checkpoint inhibitor is 3 weekly. Irrespective of whether you're using carboplatin or not, in the post surgery setting for patients who have not achieved a PCR, depending upon whether they are BRCA positive or negative, you would end up using either capecitabine or olaparib. So this is how you kind of apply platinum. Though Dr. Gupta's study did not show the difference. One of the things, I don't know whether you went and saw that, Shubhra, what was the dose intensity, or did more patients who were postmenopausal or premenopausal end up completing their treatment? Interestingly, the first thing that comes to all of our minds is that postmenopausal women will not tolerate the platinum well. They would have gotten lesser platinum, so they didn't do well. That's what we would all think. But interestingly, whether you were premenopausal or postmenopausal, only around 75% of patients were able to complete protocol. Approach this point of carboplatin in the exam. Right, Nihanti, I'm done.
Yes, sir. So you're on time, sir. And apologies from my side because you were explaining so beautifully, we couldn't stop you, sir.
That's a polite way of saying you exceeded time, Nihanti.
No, no, not at all, sir. Sir, Akhil sir is stuck in the OPD. So I request Chandrakant sir to please give the final remarks.
So I think it was just fantastic. Nothing short of it. So Dr. Sendil took us through each finer aspects, and it's a learning for all of us, especially what does uh, p-value, how to look at p-value, what about both sides. So these are very important in practice, and how to interpret these data into clinical practice is what it all matters. So I think we had a wonderful discussion. I would thank Sendil sir for his expertise and for taking out time to teach. In fact, initially we had thought of a jumbled up way of discussing and criticizing trials, but it was Sendil sir who gave an idea as to how we need to conduct this session, and now we understand why it is important to read between the lines in the paper, and as trainees and also as consultants, how important it is to discuss the results, how we obtain and how to take into practice. So with this, I would thank Nihanti. I think Nihanti had a great role in coordinating all of us together. And I would thank all the members of ISMPO. Padmat sir, I saw him texting, Dr. Vinayak, Dr. Smriti, Sham sir, everyone for helping us having this event. And every month on a third Tuesday, probably second Tuesday, we are planning to have these ISMPO events, journal clubs every month by different DMGs. So I would request all the students to be waiting for this and learn from experts the way Sendil sir did today. So thanks again, Sendil sir, for sparing your time. Thanks all of you.
Pleasure is mine.
Thank
Good
you
night.
so much, sir.